Good morning, and welcome to the Virginia Interfaith Center for Public Policy's live weekly broadcast. I'm Roberta Oster, the Communications Director. Our program brings you news and analysis about economic, racial, social, and environmental issues here in Virginia. We bring the expertise and perspective of legislators, community members, policy experts, and faith leaders. We keep you informed, and we keep our elected officials accountable. In keeping with the mission of the Interfaith Center, we will share resources and offer opportunities for you to get involved in our work, advancing social justice and helping our neighbors. And the broadcast is interactive. You'll be able to ask questions of our guests during the show, right here on this Facebook feed. So please, we care what you think. Please participate. And now to today's program. Our focus is on COVID-19 in Virginia, and I am pleased to introduce a very special guest. Dr. Danny Avula is Director of the Richmond City and Henrico County Health Departments. Dr. Avula is a public health physician, board certified in pediatrics and preventive medicine, and he continues to practice as a pediatric hospitalist. He's a graduate of the University of Virginia and the VCU School of Medicine. He is also the immediate past chair of the Richmond Memorial Health Foundation and serves on many community boards. Dr. Avula has been named one of Richmond's top docs every single year from 2013 to today. Dr. Avula is also at the center of the storm of COVID-19 in Virginia. And we are extremely grateful that he has taken time from his busy schedule to be with us here today. Thank you, Doctor. And he will be speaking with my colleague and friend, Kim Bobo, Executive Director of the Virginia Interfaith Center for Public Policy. Kim?
Thank you, Roberta. And again, thank you, Dr. Avula, for joining us this morning. So, Dr. Avula, give us the big picture. How is Virginia doing in terms of fighting the virus? What have we done well? What have been some of our challenges?
Thanks, Kim. Yeah, so glad to be here with you all today. And we're 7 months into this in Virginia. Not quite, but the first case in Virginia was March 7th. Our response kind of started just prior to that as we were recognizing that this was going to be a real threat in the United States. And how has it gone? We've had a bunch of challenges. We've learned a lot. We're in a relatively good place now, but we're not out of the woods. So that's the short version. Back in March when this was just coming into the state, it was mostly sporadic cases, people who had had travel histories, who had either gone on a cruise or gone to Italy or China, or had traveled to another state that was seeing earlier disease than we were. And then pretty quickly, the front lines of COVID in Virginia became nursing homes and assisted living facilities. Through April and into May, we had just really heart-wrenching, really challenging outbreaks in those very high-risk settings. And we were just learning, how do we combat this? So many of these nursing homes and assisted living facilities were having to adapt completely new practices in terms of disease prevention. They were understaffed. They didn't have access to enough testing. They didn't have enough personal protective equipment. And the disease was spreading rapidly, and many, many people across the state were losing their lives in those settings. I think we learned a lot quickly in terms of how to identify disease, cohort sick individuals in that setting, what changes needed to be made with staffing assignments. And so over the course of the next couple of months, that started to really die down. And as we saw community spread throughout the Commonwealth really tick up, what we clearly saw in May was this deep divide between who was being most severely impacted by COVID. Invariably, it was low-income communities of color who were seeing higher rates of COVID, higher rates of COVID hospitalization and unfortunately higher rates of deaths to COVID. A lot of reasons for that, and we can talk more about that. But where are we now? We have learned more about what this disease is, who it affects, how it's spread. I think a lot of our concerns early on were related to how much of this disease is spread with asymptomatic individuals, people who aren't showing symptoms. Do we wear masks or do we not wear masks? How much is respiratory versus how much is contact spread? Should we be wiping down all of our groceries? And so I think the sort of uncertainty of where we were in March, April, and May has shifted a lot. We have a lot more clarity about how the disease is spread, but so many of those practices that were cemented in the early part of this pandemic have been hard to let go of, frankly. And so I think we are continually learning and changing behavior as we move forward. And there's a lot there. I'm happy to go down whatever specific thread would be helpful, Kim, because I know I just talked straight for several minutes.
That was fabulous. Well, I am interested in pursuing, like, why have different communities been affected differently by this? I think we all understand nursing homes and resident care kind of facilities and why that was such a challenge because of their age and health and so forth. But why the racial disparities?
So I think there's three, maybe four specific reasons I can point to. The first is really that lower income minority residents of our Commonwealth disproportionately work in jobs where they couldn't telework, right? They are working frontline, cashier, teller at a bank, person-to-person contact. They're more dependent on public transportation, and so they're getting on buses to get to their place of work. And by and large, lower-income minority residents of our community don't have the benefit of being able to work from a phone or work from home. And so there was an exposure risk, right? The fact that they were working jobs where they were more likely to be exposed. Now, we also know because of sort of the systemic nature of health disparities, the fact that minority residents experience so much more stress, have less access to healthcare, don't have as much access to basic preventive and primary care, that we have higher rates of chronic disease in those communities, which are the exact things that make you more susceptible to severe outcomes with COVID. And so not only were those same neighbors more at risk because of exposure, they were more at risk because they had the underlying conditions that would make it more likely that they would be hospitalized. Some of the other dynamics that we've seen in terms of the spread of disease, for particularly our undocumented and non-English speaking populations, many of those families are in housing scenarios where they are packed into a small space. You have 10, 12 individuals living in a 2-bedroom apartment. And so if somebody's exposed to COVID, being able to effectively quarantine and isolate is highly, highly problematic. And so we would see rapid spread throughout household contacts. And then I think the other really important thing to point to is that people at the lower end of the socioeconomic spectrum don't enjoy the same benefits as it relates to things like sick leave, right? And so people would maybe have some mild symptoms, and then they would have to make a really difficult decision. Do I follow the public health guidance and quarantine myself for 14 days until I can get tested and figure this out? And if I do that, that means I'm not going to make a paycheck this week. Or do I take the chance with these mild symptoms and go and try to put food on the table for my family? And people just, should not, in any normal circumstance, shouldn't be in that, have to make that decision. But particularly in a circumstance where we have a highly communicable disease that could impact not only them and their families, but also entire workplaces. So that real decision point has contributed to a lot of spread. And then maybe one last thing I'll point to, this has emerged from our Spanish-speaking communities in recent surveys and focus groups that we've done, because this has, really significantly impacted the Latino community across the state. Here in the Richmond area, it's about 40% of our cases are in Hispanic Latino residents, while the baseline population in the city of Richmond is 7.5%. So a real disproportionate burden.
Wow.
and what we anecdotally see is that the Latinx community just does not wear masks at the same rates that everybody else does. We know that masks are the most effective way to prevent the spread, and there's a few reasons for that. I mean, some of it is availability, not as much though. I think part of it is I don't know how good a job we have done of providing the rationale for mask wearing in a linguistically and culturally appropriate way, in a way that people really understand. There are themes that have been described to us by our community health workers and our experts in Hispanic marketing around machismo, this idea that if I'm wearing a mask, I seem vulnerable and I don't want to do that. Or a sense of fatalism, you know, if I'm going to get COVID, then God wills it so, and He'll protect me, and so I don't need to make big changes. So a few different themes that we're seeing in that particular segment of the community that have driven spread.
Well, I want to follow up on two things that you said. One is so given the disparate impact of this disease, what are the different approaches that you and the health department are doing, and health departments around the state are doing to really make a difference to try to address some of those disparities?
Yeah, so back in April, when things were really skyrocketing, at least here in the Richmond area and really throughout the state in terms of the burden on the Hispanic community, we actually had the CDC deploy its first all Spanish-speaking team here to Virginia to work on the ground with us in Richmond and in Chesterfield County. And one of the things that they really helped us to see is that while we had enough folks who spoke Spanish in our call centers and our contact tracers, they were bilingual, but they weren't bicultural. And there's a big difference in the receptivity of many of our undocumented residents for somebody who understands that immigrant story and understands the inherent distrust that exists towards any kind of governmental intervention. And so that was a game changer for us, because we started to hire more bicultural staff, and we started to work through nonprofit partners who were able to employ undocumented residents. And that just changed the level of credibility, the level of trust, our ability to kind of convey information to many of those residents. So that was one big piece of how we changed our approach. Secondly, you know, early on in the days of testing, we really focused our community, and continue to focus our community testing events on low-income minority communities. And that was hard up front, because, you know, I remember the first week we were putting those test dates out there, the social media response was like, don't come into our community and test us. We're not guinea pigs. And there were threads like, hey, the health department's trying to come and see if they can develop a vaccine from these tests. Don't participate. And so, you know, there were a lot of long-standing, totally justified, but rooted in the challenging history that particularly African-American residents have faced with government and with healthcare, in the way that we have just abused those communities over decades.
Wow. So, that's so helpful. So tell me, I want to go back to paid sick days. You probably know that we have led for the last year on trying to get a paid sick day standard in Virginia. We've gotten it through the House a couple times now, but we are struggling to get it through the Senate. So both, what would you say to senators about why they should do this? And what would you say to listeners in terms of what they can do to try to get paid sick days in Virginia?
Yeah, I think there have been few things like an infectious disease pandemic that just show how connected we are to each other and how dependent we are on each other, both in like the generosity and emotional support ways, but here in a very practical, like, if I don't make a decision to quarantine myself, you may actually get exposed and become sick and then spread that to somebody else. And so I think that, that experience, particularly in our lower income communities, brought to light the importance of benefits like paid sick leave, right? Like if people don't have a reliable option to provide income for their family, that puts them in a really difficult position. And so I think from the employer standpoint, we should recognize that paid sick leave is not just about the individual and their health, which should be enough, but it's also about the health of their family, the health of any potential exposures in the workplace. And so there is a benefit really across the board for us to be more compassionate and more supportive in that way. What would I say to individuals is that democracy works. Like, go and talk to your elected officials, share stories that you're hearing, talk to people who have actually had to make these decisions, and help them share their stories. And my hope is that the more this comes into focus for legislators, they will see that this is not only good for the individuals who may benefit, but it's really good for the entire community.
So you, I'm sure, know about Virginia's emergency temporary standard for workplaces in terms of health and safety. Mm-hmm. And we're now in the process of trying to make that a permanent standard. So I wanted to get your thoughts on, one, are the suggestions or actually the guidelines in that temporary standard, are they helpful? Are they being followed? Should we make it a permanent standard? What are your thoughts on that?
Yeah, it's so hard to think about life outside of COVID right now. And so, obviously we've done a lot of support for workplaces around the DOLE standards in terms, and Kim, maybe it would be helpful to just for you to clarify what elements. Are we talking about disease reporting? Are we talking about required home isolation and reporting to the health department? Good
question. So I was most particularly interested in that it has specific guidelines that if you are a low risk place of employment, then you need to do these things. If you are a medium risk, then you need to do these things. And if you're high risk, you need to do these things. And have you seen that helps both employers and workers?
Yeah, it's hard to know. I mean, because there's a lot of rigor to those standards in terms of, spacing, plexiglass shields, PPE, leave reporting. And so, I mean, it's hard to say how important that might be in a non-pandemic scenario. Like clearly that's important in the context of COVID. I think it also will have benefits on other types of respiratory illnesses like the flu, which still is one of the top 10 reasons that people die in this country every year. So I think there are elements that would clearly have value outside of the context of the pandemic, but it would take a little bit of parsing out, because we also should recognize that some of these things are really appropriate for COVID, but also extreme compared to their baseline measures. And they're expensive and they're hard to do and they're hard to enforce from our end. And so I'd have to sit with that and sort of think through which of these makes sense for the long term. I'm not sure that the entirety of the standard does, though.
Yeah, I think the standard, at least as I understand it, is that the permanent standard is only a permanent COVID standard. Yeah. It's saying, because right now the temporary standard runs out in mid-January. Right. And I don't think, most of us don't think that the COVID is going to be gone by mid-January.
No chance.
So anyway, I'd love to know, what do you think we can expect this fall, this winter? When can we get back to normal? We all want normal. How and when can we expect we might get back to normal? And what's it going to take to get back to normal?
Yeah. So, I think there is a shorter window where through the infectious disease lens, things return to normal. I think we have a much longer window in terms of the social and economic impacts, get back to normal. As I think about where we are, what the timeline for vaccination is, we're anticipating that some of the leading trials, the phase 3 trials around vaccine will wrap up in the beginning of November. Now, as I understand it, there are currently hundreds of thousands of vaccines that are ready to be deployed as soon as phase 3 trials are completed and reviewed and shown to be safe and effective, and then the FDA does their review and confirms that. Now, if all of that happens, then we could have vaccine on the street, really for priority populations. So for frontline healthcare workers, and then likely for residents of these congregate care, assisted living facilities, nursing homes, et cetera. That could come as soon as November. Now, it will take a while for the machine to ramp up enough until we have widespread availability of vaccine. It's likely to come out in 3 phases, one for the phase I just talked about, the second for other adults with underlying conditions, residents of other congregate care settings like jails and prisons, and then lastly, we'll be focused on the population at large. I really think we're not talking about that kind of coverage until next summer of 2021. And we also have the reality that people do not trust what's happening with the vaccine right now. The messaging, the confusion, the lack of leadership from the federal government has really just raised huge question marks for anybody about, is this vaccine safe? I mean, should we take it? And so I think we're going to have a longer period of time where we're having to both prove its safety and efficacy, and where people actually get comfortable enough to take the vaccine. The other way that we get out of this from an infectious disease perspective is by having enough people who have actually been impacted by the virus itself. And those numbers are actually really low right now. About a month and a half ago, VDH did a statewide survey, just an antibody survey to see what percentage of our population has actually been exposed to COVID. And that number for the state of Virginia was somewhere between 3 and 4%. Up in Northern Virginia, it was a little higher, about 4.5%. In our Hispanic communities, it was across the state, it was about 10%. But still, like a far cry from the 70 or so percent herd immunity that we would want. So I think we're going to see this, outbreaks of COVID for the next year or so. And then the second part of that, which is the social and the economic recovery, I think we're talking years, right? Like my wife is a kindergarten teacher in the city schools. She, I think she does an amazing job of trying to engage these kindergartners virtually, but we all know that it's not ideal, right? For kindergartners who need, any kindergartner needs a certain degree of adult parental support to try to sit in front of a screen for 6 hours. And I think that's particularly true in some of our families here in the city. And so the gap is widening from an educational standpoint. The gap is widening from an income and wealth building standpoint. And so it's going to take some massive policy decisions and reallocation of capital and resources to try to narrow that gap.
So what are the best standards right now that everyone ought to be practicing around preventing the spread of this disease? Again, there was such confusion. Should we wear masks or not wear masks? And is 6 feet enough? Should it be 12 feet? And anyway, so I'd love your thoughts on what, based on what we know, are probably the best standards for right now.
Yeah. So what we know is that this disease is primarily spread through respiratory contact. So if I'm infected with COVID and I'm talking and I'm coughing and sneezing, I'm ejecting respiratory particles into the air that hang out in the air for any period of time before they either dry out or flutter down to the ground. So mask wearing is actually incredibly important. It's not perfect. It doesn't block every respiratory particle, but when I have a face covering, it blocks the majority of those respiratory particles from being in the air where somebody else can then breathe them in and become infected. So mask wearing and distance. I mean, the other reason that we recommend that 6 feet of distance is because with 6 feet, you're going to minimize most risk of respiratory particles that you then may be able to inhale. So mask wearing, distance, monitoring yourself for symptoms. We were really concerned early on that like a huge proportion of this disease was asymptomatic. I think we really just didn't understand what some of the other symptoms were. And so we called cases asymptomatic when we didn't recognize that nausea or a loss of taste and smell was a sign of COVID. And so I think the thinking on asymptomatic disease, while still true and present, particularly in younger kids, is less true in older adults. And so as we understand better, and now on the CDC, there's a full list of 11 symptoms, and we should be monitoring ourselves for those symptoms. And if we have any of those symptoms or any concern that we've been exposed, we should get tested. And we should exclude ourselves from group gatherings. So those are some of the key things. Hand washing is definitely helpful, but less than 5% of COVID transmission happens through contact. So we should still do it. It's going to limit flu transmission and other respiratory disease, but less important than we previously understood with COVID.
So what about, we're the Interfaith Center. What about some of these congregations that so want to get everybody back to services? What would you suggest that they ought to be doing?
Yeah, I think there's a few things, and I've seen it. I mean, I've consulted with a number of pastors and other faith leaders on, what can we do? When can we do it? What does it look like? And what's interesting, Kim, is that some of the willingness and desire to do that really breaks down along racial and socioeconomic lines. And part of that is just the lived experience of people, right? Like members of our Black communities have a much more personal connection to COVID than members of the upper middle class white community, right? Like they have had family members who have been hospitalized, or a member of their church who has passed away. And so it just feels so much more real and tangible, and creates, understandably, fear and anxiety because of those lived experiences. So I am very much seeing a divide in terms of the aggressiveness of returning to in-person faith communities. There are ways to do it. I think a lot of communities have adapted to outdoor services. They're being really thoughtful about spacing. They're trying to, in whatever way they can, facilitate some kind of human connection and community, but it's hard, and people recognize that. So I think, following the same guidelines around distancing, around hand washing, around excluding yourself if you have symptoms, if applied to a group setting, ideally outside is much safer than inside. But then, if that's not an option, spacing appropriately in indoor settings can be done. At the end of the day, your risk is a function of distance and time, right? So the more time you spend around other people and in closer proximity, if someone's infected, you have a higher risk of becoming infected. And so kind of thinking about those principles in the way that we set up the rhythm of a worship service.
So, I've talked to a lot of folks who are just like, I'm tired of this. I'm tired of this. Like, what would you say to all of us who are, we've been doing this for 6 months. I'm tired. Yeah. What would you say?
Well, y'all, I'm tired too. I'm right there with you. We've got 5 kids. We've been trying to figure out how to do this virtual life. We've been trying to be good about staying mostly quarantined. And it is exhausting, and it requires just a tremendous amount of discipline. And I think what I would say, what worries me most is that this is hard, and for the most part, I'm not sure that we collectively have the stamina to stay with this for as long as we're going to need to stay with this. I fully anticipate that we're going to see another spike in disease across the Commonwealth, particularly as we head towards the winter months. More people are spending more time indoors. We get into the holiday season, and so I think my plea as a public health professional is that we've still got a long road ahead of us. I see us as trying to grapple with this for a year or longer. And so we've got to stay committed to those core things that work. The other thing that I would say is I absolutely understand people's hesitation around vaccination. I understand the distrust of the federal government, and so many other things. I think part of our role as local public health and our Commonwealth is to start to provide good information so that people can start like understanding what is the vaccine trial process? Is this safe or is this not? What safeguards are put in place through the federal government surveillance systems? And then to make a more educated decision about whether you feel comfortable doing this or not. We can't compel anyone to do this, but we've got to make decisions that are made based in fact and not in fear or in personal experience. And so that would be my other plea for us to really like grapple with this based on good information.
Well, I have just two more questions, and then we're going to probably have to bring this to a close. This has been so helpful, though. When we think about, okay, if we're going to have to survive for another 6 months or a year or whatever, what are the policies that Virginia could do to really help families survive? People are getting evicted, they don't have food. What are some of the broader, the social indicators of health, right? What are some of these things that we as a state, as a Commonwealth, need to try to address so that people can get through this?
Yeah, I think three things come to mind. One, you mentioned the eviction crisis. Like, we just need to take housing stability off the table right now, right? Like, we've got to find whatever financial answer there is to keep people stably housed, because once you remove that, everything unravels. Second, like, income is so important, right? People need food, they need to survive. And so we've got to figure out how to route as many of these emergency funds to families on the ground as possible, and to try to just remove the stress of trying to figure out this life without the resources to do it. And then third, I worry a lot about the school gap. And there's a part of me that absolutely understands both teacher and parent hesitation about returning to in-school. I do think that there are ways that we can do this safely, and knowing that not everybody's going to want to go back. And so doing some kind of hybrid system where people, based on their risk factors and their comfort levels, can return. And so what's the policy fix there is that we've got to fund and support schools to be able to have the personal protective equipment that they need, and to be able to have the access to testing they need, to create an environment where it's safe for our highest risk academically students to be able to get back in the classroom and really invest in them in a more meaningful way than is currently happening.
Great. So the last question really that I have for you is around Virginia and how we're doing compared to folks. As I look at some of the maps, it looks like we're doing not too bad. And so I want your thoughts on, what we've done as Virginia that you think has been really good. And then, what are the places, if we're going to have to endure this for another year, where are the places that you think we really, as a Commonwealth, need to invest?
Yeah, I mean, I think when you do look at snapshots of the national data, Virginia is definitely in the better half, right? We are not, for the most part, where we have been on a downward trend of cases. Again, this is really volatile, right? Like, I expect as we head into the colder months that's going to change, but other states are experiencing that earlier. So I think Virginia has done a lot of things right. For one, the governor acted quickly to mandate mask wearing. The state government has deployed a lot of dollars to both support businesses and to support individuals. I think the Dolly regs, and even though it's really hard and it's been hard to, like, the health department does a lot of the enforcement around mask wearing, and we're pulling permits on restaurants who aren't compliant, and we're issuing notices. The fact that we even have a legal infrastructure to be able to pursue has been an important part of this, and it would have been helpful for that to happen sooner with more resource. But it's there, and it's contributed to our success. I think the fact that we have a state integrated local public health system, the fact that all of us health directors and health departments across the state belong to the same agency, we're talking multiple times a week. The central health department has done a great job of information sharing to the local districts, and then providing resources to do testing. And now we're setting up mass flu vaccination and preparing for mass COVID vaccination. So I think the coordination and integration of that response across the state has been a real strength.
That's great. That's great. Well, as we go forward, I hope we can call on you we want you to testify in favor of paid sick days for sure. So we'd love your help on that. But we also want to tell you if there are ways we can do more to support you and the work that you're doing in Virginia. We'd like to do that. So thank you so much, Dr. Avula, for who you are, what you're doing, your commitment to protecting us. It's really impressive. So thank you so much for that.
Thank you, Karen. Really appreciate it. Happy to come back. So we'll talk soon.
All right. Bye-bye.
Take care.